Now,
Good evening, sir.
good evening. So I'll just share my screen with you people. Okay. So today's session is a bit of, you can say, it's a smaller kind of session because we'll be discussing few of the cases that I had seen, and I'll be sharing the real life scenarios with you. So we'll discuss that, and if you have any queries, we can discuss it in the later stage. Okay, I'll just share the screen. Okay, so I hope the screen is visible to you. Is this visible to you?
Yes, sir.
Yes, sir.
Yeah. So we have today the series for case studies and clinical application in geriatric care. So I'll be sharing few of the cases which I have seen in my case. So introduction to the geriatric care, it focuses on the health and well-being of the elderly patient and addressing the complex medical and social needs. The objectives basically will be to present the case studies, highlighting the common challenges, illustrating the clinical application and management strategies, and discussing the outcomes and best practices, what you can do with the geriatric care. Coming to the key principles of the geriatric care, the first and foremost thing is a comprehensive assessment. Evaluating the physical, mental, and social health for the adults is very, very important so that you can give them the proper support which they actually require, not the point which you feel that they might be needing, because the root cause for their problem might be different from what you are expecting, or the underlying things are actually trying to incorporate or say. Okay, so we need to understand this thing and to make sure that we give them a proper management, we need to have a comprehensive assessment at hand. Then coming to the multidisciplinary approach with by engaging the healthcare professionals from various fields, as we discussed in our last few sessions, that taking care of a geriatric person is a team effort, and always taking care of the geriatric as per the requirements. Like they have multiple issues at hand, like for speech and hearing, they might need a speech and hearing pathologist or audiologist for the same. Then you might need to consult a geriatrician for their regular problems, and you might need an OT as well, or a practicing geriatric nurse, or a caretaker, or a JAPA nurse. People, multiple people who are working actually in the healthcare setting, which can help you to manage the geriatric patients. Then you have to make sure that it is a patient-centered care. Customized care plan based on the individual needs and the preferences should always be taken care. Geriatric is just like when you are working with the children's. Just the children's are over the age of 60, and they will be having a similar kind of tantrum, similar kind of problems. And as we usually say that every child is different, every child is special. Similarly, every geriatric person is different and every geriatric patient is special. So we need to understand that because they come from different parts of the society, they come from a different lifestyle, they come from a different perspective altogether. It is very important to have a customized care plan based on their individual needs and preferences. So coming to the first of the case study with falls and mobility issues, the patient's name, I have changed the name of the patient. The name was Mariam D'Souza. She was a 78 years old lady with a medical history of osteoporosis and previous hip fracture. She was living alone and was presenting problems with frequent falls and difficulty with balance, and there was a risk of osteoporosis fractures. So we assessed for the risk factor for osteoporosis, medication side effects, and cluttered living space. And the tool we used was fall risk assessment and medication reviews. While doing for the clinical application, the interventions, we gave her a physical therapy program which specifically worked on her balance and strengthening. And we suggested some of the home safety measures, like including grab bars, or by removing the rugs which were present in her houses, and by replacing the very heavy furnitures with easily movable plastic or wooden furnitures, so that she might not get all these chances of fall, or like injure herself in moving the furnitures and all, and try to make sure that her all the necessities of the daily livings are well within her approach. She does not have to climb up or down for reaching any kind of cupboards or anything like that. The medication adjustment was done to minimize any kind of dizziness that she might be possessing, and similar was actually done by consulting with her uh, family doctor. With the treatment plan, the physical therapy sessions lasted for at least 3 times a week, and an installation of the safety feature at home was done immediately after 1 week of the assessment, and a regular follow-up with the geriatrician was suggested for the patient. The follow-up was done for ongoing home safety assessment and adjustment to the physical therapy as needed, because as the patient actually improved in her scores, we improved the level of difficulty so that the patient got better and better. The outcome, what we got in that particular situation, was reduction in the number of falls and improved mobility and confidence in ADLs. So the patient was very, very happy, because after 3 months, when we actually discharged her from our care, and we suggested her to be on her home exercise program, and that was also telemonitored for a few weeks. She was very happy that she was able to go back into the society and function properly. So this was one of the biggest win for us, because the society actually accepted her very well, and she was like a very jovial lady. She liked to meet people, and she liked to talk to them. So she got back that life into her daily schedule, and she was very happy with this. So this was the case study number one. Coming to the second case study, which was the dementia care. One of the patient which we got was for the dementia. Name was Jagdish Mathur, and his age was 82, and his medical history was an Alzheimer's disease, and he was having daughter as a primary caregiver. Now this happens quite a lot. I've seen this quite a lot, that the people who are actually giving the care are majorly the daughters, especially if they are married. Sometimes it is very like problematic for the caregiver as well as the patient, because sometimes it comes onto the mind, like they're thinking that I have to take care, I have to take care from my daughter, although she has her own family, but she has to dedicate her time to me. So this actually gives a burden to the patient as well. But once you actually try to talk to the patient, you have to make them understand that your whether be it your daughter or son, it's the responsibility of their childrens to take care of them when they are at need. And anyone who is doing care for them is doing out of the gratitude what they have done for them till now. Now it's their turn or to get onto the receiving end. So the presenting problem was severe memory loss, aggression, and confusion. On in the assessment, we went with the mini mental state examination for the cognitive testing, and caregiver stress and support, which was needed for the assessment. Okay, so because the caregiver was also on a stress, as I told you, that she was also having her own family, so she was trying to manage everything with the job, with father's medication and management, and with the baby and husband. Although the husband was very supportive, but still she sometimes got fed up and sometimes got quite stressed. We need to tackle that as well. Coming to the clinical applications, in interventions, we went for the cognitive therapies and reminiscence therapies. Then we went for the medication for managing the symptoms for stress and like aggression and confusion. So, donepezil, we went with the management of with the drugs, donepezil, which was again suggested by proper consultation with the geriatrician. and we gave the caregivers a support group number. So there people used to come and discuss the conditions of their patients. They used to bring their patients as well. So the patient also got a and the patient also got a support group for their particular disease. Like in cities like Ahmedabad, Rajkot, and Mumbai, and even in Delhi, I have seen the hospitals organize weekly or fortnightly sessions for a specific disease group. Hello?
Yes,
Am I
sir.
audible?
Yes, sir.
Yes, sir.
Okay. So these kind of uh, groups actually provided a mental support to the patient as well, that they are not alone and they can actually learn from the people who have gotten benefit from the like treatments, multiple kinds of treatments. So they get better and better in many multiple ways. Similarly, the caregivers, because the stress for the caregivers is not new. Every caregiver sometimes go through these kind of stress, some one day or the other. So the best part is that they usually gave the support to each other rather than one going to a doctor or one going to a physio for the support. It's easier for the caregivers to get the supports within their own community and understand the challenges that the others faced and how they overcome it. So that is the best part of that caregivers support sessions every month or every fortnight. The outcomes was stabilization of the cognitive symptoms and improved caregiver well-being and coping strategies. So all these things were taken from that. Coming to the third study, which was a chronic disease management, we had a patient. And now this patient was I when I was there in South, so I saw that patient, and her name was Hema Shetty, and she was 75 years old. She was having a history of diabetes and hypertension, and presented with a problem of poor blood sugar control with frequent hypertension spikes. And while we did the assessment, we checked for the blood glucose log, which was maintained by the family. And there was an evaluation of the medication adherence and lifestyle factors. The clinical application, what the interventions we did was, first of all, the dietary counseling and diabetic education was done for the patients. Then we went on for the medicine adjustment with the insulin regime optimization with the we educated the patient for the every time bolus and basal shots. So we put the patient on the one basal shot and bolus shot based on whatever the calorie she was taking at that point, and we went for the calorie counting technique, and we asked the patient to go for the bolus shot every time she used to eat anything which can spike her sugar volume. And regular monitoring of the blood pressure and blood glucose level was also done. So in the treatment plan, we introduced a tailored diet plan, adjusted the diabetes and hypertension medications, and went on with the regular checkups and monitoring. Follow-up was done by ongoing assessment of the blood sugar and blood pressure and dietary and lifestyle adjustment as needed. And the outcome was we got a very improved blood glucose and blood pressure control with an enhanced patient quality life and reduced signs and symptoms. So this was very, very easy for us to maintain or manage, because the patient was well educated, and the things that we actually conveyed to her, we actually not conveyed to her, but we made her educated about her healthcare and her needs. So she took it more religiously, and she went on with the proper therapy by herself as well, and made our task easier. Okay. Coming to the end of life care. Now, this was one of the very serious cases that I took up. His name was Victor. Again, and this was from South, and his age was 85. And he was a case of terminal cancer with a pain management and emotional distress at end of the life. And he was especially a case why he was very problematic for us, because when I was introduced to him, he was in an old age home, and he was having that problem or that feel that his family, when he needs him, now left. So this became a challenge for us to make sure that the family is near him now when he is going for a rehab, or now when he is going for a end life care. So we went for a palliative care for pain and symptomatic management. We did an emotional and spiritual needs evaluation for all these things. And through the spiritual, emotional and spiritual support, we gave him through the counseling and hospice services. Until and unless the family was not there, we were the family, and we started working on him to make him more comfortable and make him be cheerful in everyday life with the help of hospice care. And once the family was ready, and they came on our request, so we got a family support and guidance so that they can also manage the patients well. With the treatment plan of implementation of comprehensive palliative care plan and coordination with the hospice service for the end of life support was the one of the best things that we did with this particular case. And continuous pain management and symptomatic relief was the thing that we actually went on with the this patient, and family meetings to address the needs and concern was done. And the outcome measures which we used was effective pain management and comfort, positive feedback from family regarding the care quality. So what we got here from here was not the numbers, but the actually the feedback that we were getting from the patients. Am I audible to everyone? Yes, someone's
Yes, sir.
mic is open, right? You can they pause themselves.
Yes, sir, you are audible.
So, coming to the physiological changes in elderly, what kind of physiological changes we usually get is one of them is reduced gastric acid secretion. The elderlies usually get a lot of bloating, a lot of digestive issues because the gastric acid secretion in them is getting reduced day by day because of degenerative changes which is happening in the physiology and reduction in number of the chief cells which actually help to secrete the gastric acids. Decrease in the gastrointestinal motility because of the changes in the gut, the changes in the neuromuscular system. There is a decreased gastrointestinal motility, reduce in total surface area of absorption because of so much of exposure to so many toxins, so many other things. The total surface area of absorption, which is there for the elderly, is quite reduced as compared to an younger person, younger counterpart. Okay. There is a reduced splenic blood flow, and because of this reduced splenic blood flow, the RBC destruction and RBC production, all this cycle is actually not going on very well, and this can cause a patient to go for anemia as well. There is a reduced liver size and reduced liver blood flow. Because there is a size change in the liver, there can be a blood flow change, and these blood flow changes can also be because of the conditions like atherosclerosis or any other kind of vascular changes or the cardiac changes that the patient might be going for. There is a reduced glomerular filtration and renal tubular filtration, which is again one of the primary causes for multiple disorders like kidney failure or any kind of other disorders. And this, as you all know, plays a very, very important role in regulating the blood pressure for the patient. So if these systems will not be working properly, the patient will be having problems in their blood pressure regulation as well, and might suffer a major setback in their healthcare. Coming to the drugs that can cause hypotension, we have to be sure that the patient is not taking any kind of drugs that can lead to hypotension, because we need to understand one thing: we can treat hyper things or hyper conditions very easily as compared to a hypo condition, be it hypotension or hypoglycemia. Whenever we are in a condition where we have a situation of something going less than the required amount, it is very hard for us to replenish it that quickly. But if it's going in a hyper condition, it can be fairly easily. So we need to be very cautious about hypotensive conditions where the antihypertensive drugs with alpha receptor blocking effect like tricyclic antidepressants, phenotazines, and some butyrophenones, can cause hypotension, and we need to keep a check on the medications that the patient is not taking all these kind of drugs very frequently. The drugs which decrease the sympathetic outflow from the central nervous system, like barbiturates, benzodiazepines, antihistamines, and morphine, should be always given under proper monitoring. Morphine, especially when we are giving them in the end of life care, when the patient is under immense pain, we should not leave the patient unattended, because they can go for a hypotension as soon as the patient is unattended, and can collapse pretty easily. Anti-Parkinson drugs like levodopa and bromocriptine can cause the patient to have a hypotensive situation. So make sure that whenever the patient is taking all these drugs, they are being monitored very carefully. Drugs which can cause confusion in the elderlies are like anti-Parkinson's drugs, barbiturates, benzodiazepines, diuretics, hypoglycemic agents, monoamine oxidase inhibitors, opioids, steroids, tricyclic antidepressant. All these drugs can cause confusion in the elderlies. Now, some of these drugs are actually repeated. Now, what happens? Why they are repeated here? Because once the patient is going for a hypotension, the blood supply towards the brain actually reduces quite a lot, and at that point the brain goes in for a delirium or a delusional state, and will can cause a confusion in the mindset of the elderly. So we need to be sure that the patient is not going for any kind of drug reactions because of all these drugs, and they have to be monitored properly. If any kind of signs and symptoms are there, we need to discuss with the geriatrician properly and manage the case accordingly. The elderly populations are more sensitive to benzodiazepine, warfarin, digoxin, which puts them at the risk of Parkinsonism, stroke, osteoporosis, arthritis, hypertension, cardiovascular disease like myocardial infarction, for urinary incontinence, constipations, and leg ulcers. So we need to be sure that we do not make the patient to fall under all these category, and if any of the symptoms are there, we need to consult with the doctor as soon as possible. So what are the common challenges that we usually face in the geriatric care? One of the major problem is medical complexity. Managing multiple chronic conditions and polypharmacy is one of the biggest problem. I have seen that in the patients, that sometimes the patient becomes very rigid. And their point is also quite correct, because if the patient has reported that they cannot take any drug orally, it induces or it increases their sensation for vomiting. And if the patient has to take three medicines for three uh, ailments which are actually going on in the body, so they are the comorbid diseases, and you cannot leave them at any cost. So a patient who is not able to take one drug, you are actually putting him or her on three drugs. So it can become quite difficult for the patient to match up to the requirements, and can complicate the problems unnecessarily. Then you have polypharmacy. Again, we need to be very, very careful while providing the drugs to the patient, because sometimes these drugs cause reactions which can be because of use of each other. So we need to tackle that as well. Then we have to understand about the psychosocial issues and addressing the isolation, mental health concerns, and cognitive decline. Going for a proper assessment will give you a brief idea about the current mental state of the patient. And once the mental state of the patient is clear, you can always go for the management of the patient for the underlying cause of the problem. Sometimes the patient will not be having the cause because of musculoskeletal or the neurological aspect, but the patient will be having a problem because of the psychological aspect. And once you clear or correct the psychology, or you take the first step for correcting the psychology, the patient starts to benefit from the day one. Okay, then you have to understand for the care coordinator, ensuring the effective communication among healthcare providers and family members. You need to be very sure or very communicative about the health types of conditioning that they are providing to the patient, and how they are actually managing the patient. You need to train them as well. So what are the best practices and recommendations that we can do? A patient-centered approach with focus on individual needs and preferences should always be done. A multidisciplinary team with collaborative effort from various healthcare professionals in holistic care, and continuing education by keeping up to date with the latest advancement in the geriatric care is one of the best practices which you can always do and continue to maintain the patients. You need to update yourself as well. You cannot treat the patients on the same way as we used to treat the patients 20 years back. Okay, so we need to be sure about this thing. So on conclusion, what we can understand is that with the reviewed case studies we have tried to highlight the diverse challenges and effective management strategies in the geriatric care, and emphasis on the ongoing research and innovations in elderly care is required for improving the outcomes in elderly patients. Now we are actually working towards this particular kind of scenario as well as last year when I was there in the IEP conference. So they actually, what I remember is they released a book specifically for the geriatric care. So you can always see all these things and try to um, understand that the scenarios are now changing and now you can super specialize in geriatric care as well. So these were few of the references that I used for these patients, and thanks. And this will be all for the today's session. If you have any queries, we can discuss this now.
Hello,
What
sir.
is reminiscence therapy? Am I audible?
Yeah.
Farzana, you are audible, but someone's mic is on, so things are not clear.
Yeah, am I audible now?
Yes, sir, you're audible. You were not previously audible.
Okay. So
Sir, what is this reminiscence therapy?
yes, I'm telling, I was telling that only. One of your colleagues also asked this. So reminiscence therapy is like one of the therapy which we give to the patient for feeling better. See, if, like every individual, you have your memories associated with multiple things. Like if I'll give you an ink pen, you might be having few of your memories with your ink pen, like whenever you were there in school, and so you were having some good times, some bad times, so you might be attached to it. Similarly, in reminiscence therapy, we use the to recall the past experiences, add to the sensations, add to their feelings of happiness or feeling of goodness, like with the use of a kind of music, a kind of scenery, a photograph, and especially to elicit an response from the patient and make them more socially available for others. Okay, so sometimes it can give you very good results. For example, like some people associate a sort of song with a sort of uh, you can say weather. Like for me, there is one song which I usually associate with winter. So whenever I actually hear it, I feel that kind of weather, that it's a cool breeze which is blowing, and it's a time of November or December. And if I'm driving or I'm walking on a street or I'm riding a bike, so that kind of cold wave is actually hitting me, and that's mild wave. So whenever I'm even
What song is that, Dr. Badri?
what?
What song is that, Dr. Badri?
See, that's personal for everyone. Uh, it can be
Just,
anything to do
I
with.
mean, with your kind of explanation, I was really, excited to know about the song.
See,
Maybe it gets
for
my
me,
favorite.
that song. See, for me, that song is from Rockstar. That was one of the movie in the Bollywood, and
Yeah.
so Rockstar is having that song. Um, mm, like I'm not remembering the lyrics right now. I don't know what happened to me, but yes, I remember the movie. Tum Ho, that's the song name.
Oh,
So
yeah.
because when
बहुत अच्छा है वो तो.
yes, I know that's a great
हाँ.
song.
Yes,
And
I.
now
Thanks for
why I
sharing.
actually like it or why I have that memory, because when that movie actually released, uh, and I used to listen to those songs. I drive quite a lot at that point, and during my travels, because it was winters, so I always associated it with winters. And in fact, that song also has a scene in which they have a scene like that. They are driving and winter breeze is falling onto them. So that is something which is associated in the memory. And when we take that thing and associate it with the patient's feelings as well, we can elicit a very good response from them, especially the patients who are not able to understand or feel that kind of things. Okay, so
Right,
that is
sir.
the
Thank you.
business. Any other queries?
Dr. Badri, I have a patient part of suffering from Parkinson's, and
Okay.
he has difficulty in walking,
Hmm.
balance issues and stuff.
Hmm.
He's taking levodopa,
Hmm.
and one of the I think medicine specialist who actually diagnosed Parkinson's in his case, he
Hmm.
recommended, he was having pain in musculoskeletal system and stuff. He actually recommended tramadol, a morphine based
Hello. Hmm. Hmm. Hmm.
painkiller. And I was
Hmm.
surprised to see that. I mean, the patient has coordination issues, balance issues, and tremors and pains, and you're recommending tramadol. I mean,
Hmm.
I mean, I'm sorry for my, choice of words, but how dumb is that?
See, again, it's a choice of drug that people usually do, and I have seen such kind of practitioners in my practice as well. In fact, today only I got one of the practitioner. He sent the patient to us with all the things written that what we should do in physical therapy, and he only gave the recommendations for the machines and all. So my first and foremost response to him was very politely. I said, "Sir, this is my area of expertise. I'm not putting up my expertise into your field. So let me handle the patient my way." Um, I made him understand that the machines won't be actually helping the patients, because the main problem for the patient is coming from somewhere else, which actually required a biomechanical correction. So he understood that, and I hope sooner or later everyone will actually understand the worth of physical therapist, because the changes are meant to be done. So yes, these kind of things happen, and what you can do from your part is, okay, if they have given the tramadol, just make sure you educate the patient about the side effects of the tramadol, and in your treatment protocol, incorporate such effective pain management strategies that the patient can be weaned off from tramadol very easily, because otherwise the management protocol for Parkinson's can be hampered drastically, and you will be running after the other problems or other side effects of the tramadol, rather than going for the management of Parkinson's full-fledgedly.
Okay, Badri, in Parkinson's patient, what
Yes.
kind of non-medical pain relieving things we can do, or what kind of, alternatives we have?
Whatever kind of pain management strategies you want to take up as a physio, whatever kind it is, I haven't seen any of the papers stating that we cannot use these kind of pain relieving modalities in the Parkinson's patient. We can use TENS, we can use IFT. We have to just make sure that the patient is not sensitive, or the patient is not having any kind of reaction to it. Okay.
Right.
If the skin sensitivity is good and the patient is able to tell you about the temperature, the current, and everything, you are open to use anything. There is no contraindication as of now. I haven't seen any kind of contraindication.
Definitely. Yesterday, I saw the patient for the first time. And
Okay.
he himself told me that whenever I used to have tramadol, I'm sleeping all day. I
Yes,
mean,
so you can
no
ask him.
activity.
You can
Yeah,
ask him, see, once you are with me, you are having pain, we'll be putting up some pain management strategies as well. We'll be giving you some machines. It will help you to manage pain, and you need to take tramadol only and only in super emergency cases where you cannot bear the pain anyhow. If you are able to bear the pain, please do these kind of strategies, put ice or put hot pack, or whenever I am with you, you just tell me, we'll put up some TENS or IFT or some other modality so that we can relieve your pain and you can get on with the things easily. Please don't put yourself on multiple medications.
right, Dr. Bade. Thank you.
Sure. So any other queries?
Sir, what can we do in a case where, due to long-term use of psychotic drug, patient now seen with symptoms of majorly rigidity and we can say Parkinson's symptoms because of long-term use. Example, Sizodum, Tetrafol,
Hmm.
around
So
1 year drugs.
these kind
As
of
it is also a side effect that
hmm.
regular use of these psychotic drugs can lead to these
Yes, yes.
symptoms.
So these drugs are actually very notorious and known for causing Parkinson's like symptoms. So first of all, we need to understand and assess the patient thoroughly for whether the patient is having Parkinson's or is having Parkinson's like syndrome, because both are two different conditions. Once you are done with the assessment, side by side you start your management strategies for reducing this rigidness, like putting up the patient into a splint or giving the stretchings and asking him for the multiple visual or verbal cues for managing the postures, advise relaxation techniques. If the patient is able to relax easily, go for a meditative guided exercise therapy. Put up the patient for other kinds of therapy which can help the patients, like cognitive rehabilitations and for functional trainings into the patient, which can actually lead to very good results. But first of all, you need to make sure that what kind of patient he or she is, whether the patient is having a pure Parkinson's or Parkinson's like conditions.
Okay, sir. Thank you, sir. Sir, should we tell the patient to stop these drugs?
If he or she is not able to live without it, we can't actually stop the drugs directly. We have to consult with the consultant as well. And if the patient is okay and he can be weaned off from those drugs, maybe the dosage can be reduced. This will definitely help you to manage the patient very well, because stopping the psychotic drugs abruptly can cause multiple problems as well if the patient has become more dependent onto them. So we need to again, this is a team effort, so we need to discuss with the consultant as well.
Okay, sir. Thank you so much, sir.
Okay. Anyone
Sir, what
else?
can we do in the cases where we should do something else, but we have to listen to the patient? Like the patient is very rigid about his own thinking. So what should we do in that case?
See, first of all, we need to.
Majorly, it is seen in elderly only.
Yes, it is seen. So what we need to see, we need to do is be a patient listener first. Listen to the patient. There, in that, you will get the reason for their rigidness. And once you get to their reason of rigidness, why they are rigid for that, try to mold it with the education by educating the patient about, see, this is your thing, you are saying this thing. I'm also doing the similar kind of thing, but in a different manner. Okay, so give them rationale in that particular sort only, where they are getting the solution for their things, and they feel that they are getting the solution in their own way, and also getting the knowledge about something which what you are doing. We cannot, if they are rigid, we cannot be rigid with them directly. We have to mold our way. That's why with the patients we need to keep your patience levels quite high as a physio, because we are spending quite a lot of time with the patient. We cannot say that we cannot treat you like that. We
Yes,
have to
sir.
keep our patience We have to listen to the patient. We have to match up to their expectations. We have to keep them in the loop and respect their opinions as well, and modify our treatment protocols by educating them as well. So if we are
Okay,
not
sir.
able to start with one treatment as of now, right now only, but after 2 to 3 days, try to mold the patient, and elderlies will get molded easily.
Sure, sir. Thank you so much, sir.
Any other queries?
No, sir.
Anyone else? I think we can call it a day. Dr. Vipin, I think that's all for the day.
Thank you so much, sir, for today's session.
Okay.